Welcome everyone to the Clinical Pharmacology Training Network webinar series. I'm Dr. Sarah Quinney from Indiana University. I lead the Maternal Pediatric Precision Therapeutics Hub Network and am filling in for Leslie today as she's on leave in moderating today's session. Our speaker today is Dr. Holly Roviza. She's an infectious disease physician at Brigham and Women's Hospital and an assistant professor of medicine at Harvard Medical School. She completed her residency in internal medicine and pediatrics at Duke University and infectious disease fellowship at Mass General in Brigham. For over 15 years, Dr. Roviza has collaborated with the PEPFAR Global Fund Supported AIDS Prevention Initiative in Nigeria program, initially developing programmatic initiatives to expand HIV treatments throughout Nigeria, and is now leading research with Nigerian collaborators to address knowledge gaps in pediatric HIV care. Her research interests focus on the pharmacokinetic studies of anti-tuberculosis and antiretroviral drugs among children living with TB and HIV co-infection, pediatric HIV drug resistance, and rapid HIV drug resistance diagnostics. Her research has been supported by grants from NICHD and NIAID. So with that, I will turn the microphone over to Dr. Roviza to talk about advancing TB and HIV therapeutic strategies in children.
Great. Can you see that?
Everything looks good.
Great. Okay. It's such a pleasure to be with you all here today. And I just want to thank Dr. Quinney for the very kind introduction and also the organizers for inviting me to speak today. As detailed in the introduction, I have been working with a large PEPFAR-supported NGO in Nigeria for many years. And while I do not have a formal background in clinical pharmacology, I began work in this space when children we were caring for in Nigeria lacked treatments that were available to adults, but had insufficient pharmacokinetic safety and safety data for use in children. So I'll share some of this research that I've had the opportunity to run with colleagues in Nigeria, and I will also delve into important studies that have recently advanced pediatric HIV and TB treatment globally. So I have no financial disclosures, and the objectives, I think you all have seen these, are to describe the current landscape of pediatric TB HIV treatment and identify research gaps affecting treatment optimization, identify key developmental pharmacology principles that influence anti-TB and antiretroviral therapy across pediatric age groups, and then examine selected clinical pharmacology studies that have informed pediatric TB HIV dosing and outline priority research areas. So this is also detailed in the outline here, but we'll start off very briefly with the burden of pediatric TB HIV, current state of treatment, and then key points. I know, this group is well versed in developmental pharmacology, but we'll touch on some key points of relevance for TB HIV treatment. And then we'll spend most of the time talking about optimizing TB HIV treatment study, focusing on key clinical pharmacology studies in TB treatment, including some of drugs that we're well versed with such as rifabutin, rifampicin, and then newer drugs towards the treatment of MDR TB treatment. And then in terms of HIV therapies, we'll touch on dolutegravir in neonates, long-acting injectables, and extensive HIV drug resistance, and we'll wrap up with future research priorities. So, as you well know, pediatric tuberculosis is a major global pandemic, with TB being the leading cause of death from an infectious disease globally. 1.25 million children developed TB in 2024, and 175,000 children died of TB in the same year, despite it being preventable and curable. 73% of these deaths occur in children under 5 years of age, and 52% of TB cases in young children are undiagnosed and untreated. Similarly, the global pediatric HIV burden is also significant, with about 1.4 million children living with HIV worldwide. 120,000 new pediatric infections occurring in 2024, and 75,000 children dying from AIDS-related causes in that year. While there's been significant progress with 62% reduction in new infections since 2010, progress has slowed in the recent years. So pediatric TB-HIV co-infection presents with its own unique challenges. Children living with HIV are 8 to 20 times more likely to develop TB compared to those without HIV. And in high prevalence settings, about 25% of children newly diagnosed with HIV have active tuberculosis. And co-infection is most severe in the youngest children, where we often see up to 40 or 50% of children presenting with HIV have TB co-infection in our populations in Nigeria. 1/3 of pediatric HIV deaths continue to be due to tuberculosis, and key challenges remain, including underdiagnosis, especially in young children, limited or challenging treatment options, and higher mortality in co-infected populations. So before we delve into some of the newer data on treatment, I just want to reiterate, to make sure we're all on the same page, the current state of pediatric TB and HIV treatment, and some of the notable knowledge gaps. So this table summarizes the World Health Organization supported pediatric HIV treatment guidance, and it is grouped by age band. And this really changed around 2020 when dolutegravir became available for children. This occurred certainly in Nigeria in 2 waves, with the adult tablets being available for children over 20 kilograms, starting around late 2019, and then in 2021 when the dispersible tablets became available for children under 20 kilograms. It's notable that while currently most children are receiving dolutegravir, those under 4 weeks of age, there's still no formal dosing guidelines, but I will go over some of the early data. And we continue to use drugs like AZT, raltegravir, and nevirapine, drugs that we rarely use in adults in this population. And of course, if children fail first-line dolutegravir-based therapy, which we are starting to see in pediatric populations, second-line therapy continues to consist of lopinavir-ritonavir-based therapy. So we know that there have been over 30 antiretroviral medications approved for use in adults, with over 200 formulations of various medications. But it is notable that there are often kind of age limitations or weight limitations for many of these medications in children, as you well know. As I mentioned, dolutegravir over 4 weeks of age. Some of the newer injectable drugs like cabotegravir, along with rilpivirine, which is now first-line therapy for adults with HIV, is only approved down to 12 years of age for children. A lot of the other medications have age or weight-based limitations, and then notably most of the newer medications are approved at this point for adults only. So unlike HIV, where there's been so many new medications developed in the past decades, treatment of drug-susceptible TB, as you well know, has changed little in the past 50 years or so, with standard therapy continuing to consist of the 4-drug regimen consisting of rifampicin, isoniazid, ethambutol, and pyrazinamide for 2 months, followed by the continuation phase of rifampicin and isoniazid for 4 months. Of course, the continuation phase duration depends a little bit on the site of infection, with this typically lasting 4 months, but being extended in patients with TB meningitis, disseminated TB, or bone disease. And as of 2021, there has been some new data showing that in non-severe TB, children can receive a shorter 4-month course with similar outcomes. And finally, in 2022, a study showed a novel treatment regimen for drug-sensitive TB approved for children 12 years and older, consisting of rifapentine, moxifloxacin, INH, and pyrazinamide, which is really the first new option for drug-susceptible TB, in many decades. So, what about the progress in treatment of multi-drug resistant or rifampicin-resistant TB? Certainly there's been a lot of news around the all-oral regimens, BPALM, consisting of bedaquiline, pretomanid, linezolid, and moxifloxacin, which reduced MDR TB treatment from 18 to 24 months down to 6 months, with a success rate over 90% in adults. However, this hasn't been translated to pediatric populations quite yet. The WHO currently endorses a pediatric shorter all oral bedaquiline containing regimen, but as you can see here, this still consists of a more complicated regimen, 7 different drugs, and the duration of the therapy is up to 11 months. So there still is some room to go in terms of improving therapies for MDR-TB in children. So I'll now jump into developmental pharmacology. And again, I'm not going to go over this in detail because I know you all are well versed in this area, but I just want to accentuate a few things related to TB and HIV treatment. We all have seen this image from the New England Journal article showing the key differences in pediatric pharmacology, accentuating the fact that growth and development alter pharmacokinetics and pharmacodynamics in children in many ways due to age-related organ maturity that affects drug handling, from gastrointestinal function to renal and hepatic metabolic capacity as children develop and grow. And the important finding is that limited clinical trials have limited the assessment of these changes in children and are needed in order to carefully determine dosing and monitoring in children. So again, we'll just talk about some of the kind of very basic differences in pediatric pharmacokinetics and how this may impact certain TB and HIV drugs. And in terms of absorption, as we know, neonates typically have slower gastric emptying and higher gastric pH, which can either increase or decrease drug solubility and absorption in these young children. And specifically for weak acids, such as the rifamycins, this can result in decreased lipid solubility and decreased absorption in this age group. On the flip side, in drugs that are weak bases, such as bedaquiline, delamanid, ethambutol, the higher pH in infants can increase absorption and potentially increase toxicity. Decreases in skin thickness and greater body surface area in infants can result in increased absorption. And then moving on to distribution, the total increased total body water in neonates and young children can result in increased volume of distribution, which can lower plasma concentrations for hydrophilic drugs such as INH and pyrazinamide, requiring dose adjustments, weight-based dose adjustments in this age group. And the lower plasma proteins, which are often seen in children with malnutrition or HIV, can result in elevated free drug, particularly for highly protein-bound drugs such as delamanid, bedaquiline, and the integrase inhibitors, and this has the potential to increase toxicity. So again, all these findings are important as we consider pharmacokinetics and handling of drugs in children. In terms of metabolism, as we all know, the phase 1 enzymes such as CYP3A4 are low or immature at birth, and they increase in the first year of life, and that can obviously impact drugs, increasing plasma levels due to slower clearance and risk for side effects from some of these drugs in early infancy. while the phase 2 enzymes, such as UGT1A1, which are immature in neonates, can result in reduced clearance, and we see this with drugs like dolutegravir, where exposures can be increased in very immature neonates. And finally, excretion. We know that GFR is dramatically reduced at birth, and this may increase drug half-life, particularly for drugs such as ethambutol, levofloxacin, and aminoglycosides. And these reach adult values within 1 to 2 years. So just taking some of these points and now applying them to key examples in optimizing TB HIV treatment for children. I'll start off with some of the work that we did in Nigeria on evaluating rifabutin pharmacokinetics in children who were receiving lopinavir/ritonavir. This began my foray into pharmacokinetic studies in children because at the time, lopinavir/ritonavir was first-line therapy for children under 3 years of age and second-line therapy for any children who had failed and were above 3 years of age. So we had a large number of children who required protease inhibitors and were receiving tuberculosis therapy. For adults, we were supporting rifabutin access for adults, and that was considered standard therapy. And for children who required lopinavir/ritonavir during TB treatment, the WHO at the time recommended super boosting lopinavir/ritonavir with additional ritonavir. However, this was not available. So we thought that it was important to evaluate rifabutin PK in this population, and at the time there was really no data on the use of rifabutin in this population. So we examined this amongst a couple different cohorts: older children between 3 and 15 years of age who were receiving second-line lopinavir/ritonavir, and we dosed rifabutin at 2.5 milligrams per kilogram daily during the co-treatment. Of course, standard dosing for rifabutin, not during ritonavir co-treatment, is between 15 to 20 milligrams per kilogram. And so for young ART naive children under 36 months who were newly initiating treatment, we initiated TB treatment and first, along with rifabutin dose between 15 and 20 milligrams per kilogram, again considered standard therapy, and then reduced that to 2.5 milligrams per kilogram for children between 12 and 36 months, and a slightly higher dose for those under 12 months of age. So what are some of the considerations regarding rifabutin PK across these age groups? Well, we know that the weight normalized clearance of rifabutin is kind of highest in young children and is a little bit lower in neonates due to the immature CYP3A4, which reduces clearance and increases exposure. This quickly, with the maturation of CYP3A4A, this rapidly results in a peak per kilo rate of clearance, and so children in this age group may have a somewhat lower exposure at standard doses, and then that normalizes to adult dosing. That said, ritonavir is a potent inhibitor of CYP3A4, which can reduce rifabutin metabolism and therefore increase rifabutin exposures. And yet, for the youngest children, the relative inhibitory impact of ritonavir can appear smaller because of immature CYP3A4. So we studied this in these two cohorts that I mentioned. Our target average population exposure target was rifabutin AUC of greater than 3.8 microgram hours per mil. And the only clinical correlation that we have is one study that showed that rifamycin resistance was increased in individuals with an AUC less than 3.2. So this is how we came to this exposure, although there's no kind of formal threshold for rifabutin AUC. And we found that Children receiving rifabutin 2.5 mg per kg along with lopinavir, ritonavir had adequate exposures. It was interesting that the concentrations did seem to increase with stable adherence over time, maybe due to somewhat delay in the induction effect of the ritonavir over time. In the younger children, we evaluated, again, 2 weeks of standard dose rifabutin at 15 milligrams per kilogram during TB treatment only. And interestingly, you can see that in this red line in this rifabutin concentration time curve, where in young children, the dose of 15 milligrams per kilogram per day without ART resulted in lower exposures than 80%. This was an unexpected finding because this was considered standard DHHS recommended dosing. However, in our cohort that received rifabutin 2.5 during lopinavir ritonavir, those children achieved adequate AUC comparable to adults. So we utilize this data to inform a population pharmacokinetic model that we developed with colleagues in South Africa. And this is our final model. It consists of a 2-compartment disposition model scaled allometrically by weight for rifabutin and its primary metabolite. And as you can see here, the clearance was parameterized as conversion to the metabolite, as well as the pathway inhibited during lopinavir ritonavir co-treatment. And using this model, we found that lopinavir ritonavir co-treatment increased rifabutin bioavailability by 158% and reduced metabolite clearance by about 76%. Interestingly, we also found that severely malnourished children showed 26% lower bioavailability. So this certainly needs to be studied further, but could argue for higher mg per kg dosing in populations with severe malnutrition. We utilize the model to develop and optimize rifabutin weight bands for children both receiving lopinavir ritonavir and without. And with these doses, the median rifabutin and metabolite exposures were in line with those reported in adults receiving lopinavir ritonavir co-treatment. So this utilized data from our cohorts, pharmacokinetic studies, to kind of extend this data and evaluate both variability and weight-based dosing in this population. More recently, obviously I mentioned most children these days are now on dolutegravir-based therapy. And again, a large proportion of children newly enrolling with HIV in Nigeria have co-infection with tuberculosis. Multiple studies have shown that current WHO recommended dosages of rifampicin result in inadequate concentrations in most children. And this is despite, over the years, the World Health Organization increasing weight-based dosing for rifampicin. There's been interest in high-dose rifampicin, which may improve outcomes and shorten treatment duration. However, the impact of these higher dosages of rifampicin on dolutegravir clearance is unknown. And so we carried out an open-label phase 1/2 pharmacokinetic and safety trial to evaluate steady-state dolutegravir and rifampicin exposures in children. And specifically, we enrolled Nigerian children living with TB-HIV co-infection between 4 weeks and 5 years of age. And again, they received standard rifampicin dosage, on average about 15 milligrams per kilogram. And then they also received 2 weeks of high-dose rifampicin. And the high-dose rifampicin dose is seen in the dark green on the right in this table, and it was weight-banded dosing that approximates exposure in adults receiving 35 milligrams per kilogram, and estimated from the Optarif Kids trial. As you can see, these dosages are quite high in milligrams per kilogram dosage compared to what adults receive. So much higher mg per kg dosing needed to achieve the same exposures. So we recently presented this data at CROI this year and at interim analysis, which I'll share the data. There were 10 children, median age of 3.5 years and weight of 10 kilos. And we found that only 10%, or 1 in 10, had a RIF Cmax above the therapeutic target, which is greater than 8 micrograms per mil. And during high dose rifampicin, as expected, all of the children received or achieved this target. And we found that again, the geometric mean Cmax was 3.5 in the standard dose and 30 in the RIF high dose. We additionally found that there was no difference in dolutegravir exposures during standard RIF and high dose RIF. As you can see here, the 12-hour AUC during standard and high dose RIF were essentially equivalent, and the Cmin was very similar. So we found, in summary, we found that the standard weight-based dosing that is recommended by the WHO does not achieve the Cmax target in most children. High-dose RIF did achieve this and was without any evidence of additional liver toxicity amongst these 10 patients, and dolutegravir exposures were unchanged. So it provides, some data to support further study of high-dose rifampicin in children as an important therapeutic option, and further studies to assess whether this may improve outcomes, have the potential for shortened treatment in this population. So I'll now move on to kind of the broader work on mostly MDR TB drugs in children that have been performed by many individuals all over the world. And I'll start with bedaquiline, which, as I mentioned previously, is one of the standard medications used in MDR TB treatment and is a key component of the BPALM or BPAL regimens. Its primary side effects are QTc prolongation, liver toxicity, joint pains, and headaches. And it is classified as a diarylquinolone drug targeting the C subunit on the ATP synthase, and this inhibits ATP production, resulting in cell death, and this includes in dormant cells. So some of the key pharmacokinetic characteristics of bedaquiline include that it is highly lipophilic, and the bioavailability is significantly increased with food by twofold when given with food. So again, when considering pharmacokinetic studies in children, this higher pH and slower gastric emptying, particularly in the young children, and on average lower fat meals may reduce absorption. This could delay Tmax and reduce Cmax as well. In terms of distribution, the very high protein binding, it's about 99% albumin bound, may be a large factor in variability amongst children, particularly those with malnutrition and HIV, in whom we're often utilizing these medications. And in terms of the volume of distribution, it's very large for bedaquiline, and with infants' lower fat stores, this may result in a lower apparent volume of distribution. Bedaquiline is primarily metabolized by CYP3A4, which may result in higher clearance per kilo in the kind of young children, but not the youngest children. And then the primary metabolite for bedaquiline is the M2 metabolite, which is less active against tuberculosis, but may contribute to QT prolongation. And finally, the terminal half-life for bedaquiline is about 5 to 6 months, so very slow release from tissues, although the effective half-life is about 24 hours for the accumulation phase. So, what are the primary bedaquiline targets that we utilize in adult studies for comparison? Since bedaquiline is dosed 3 times weekly after the initial 2 weeks of lead-in phase, the target most commonly used is a bedaquiline weekly AUC of 187 micrograms hours per mil, although efficacy, as is common for most antibacterials, correlates with the AUC over MIC. Cmax is used, but is more relevant for safety and QT prolongation. So overall, this suggests that in children, the AUC may be lower for bedaquiline due to increased clearance per kilo, increased volume of distribution, and lower albumin levels, which may increase the free fraction and increase the free fraction. But despite this, the effect might be the same given the effect is in the tissues and the free AUC over MRC is preserved. So I'll quickly study or review the studies that have been reported on bedaquiline PK in children. The primary study is this TMC C211 study examining PK and safety of bedaquiline in age cohorts. Specifically, they studied bedaquiline dosing for children 5 years of age and older. In those who were over 12 years of age, they received the standard adult dose, which is 400 milligrams once daily for 2 weeks, followed by 200 3 times a week. And then in the younger age cohort, 5 to 11 years, this dosage was decreased by half. In both cases, children received a background TB regimen, including at least 3 drugs known to be susceptible. I'll additionally share results from an observational cohort study, which has also informed dosing for children over 6 years of age, and the IMPACT P1108 study, which has examined dosing for children under 5 years of age. So the C211 study showed that PK profiles were broadly comparable to adults, supporting weight and age-based dosing. Specifically, they found that this weekly AUC was comparable to adult targets within a 60 to 140% range. Typically, bioequivalence, as you know, kind of limits the range to 80 to 125, but with bedaquiline, there's a lot of variability in children, and there's a broad therapeutic window based on AUC, so they felt this range was adequate. And so in this study, the children in both age bands met this therapeutic target. And they also found that there was favorable safety, no major QT issues or discontinuations. At the same time, there was an observational study of bedaquiline PK in the first kind of real-world study. 15 children between the ages of 6 and 17 years who were receiving treatment for MDR and relatively resistant TB were enrolled. Of note, it did only include 4 children under 12 years of age, and 3 of whom were living with HIV. And their dosing was a little bit different than what is currently now recommended for bedaquiline dosing by the WHO, specifically for this mid-weight band of 24 to 30 kilograms, which is currently lower than current guidance. They carried out semi-intensive PK sampling with nonlinear mixed effects modeling, and they observed that in children there were lower exposure compared to adults, with only about 20% reaching adult AUC targets. They also observed that bioavailability was about 57% of adult levels. So this supported, some adjustment and higher dosing in that kind of middle weight band. The IMPACT P1108 study examined bedaquiline for children less than 6 years of age and has provided early PK and safety data. This data was presented at the 2024 Union World Conference, but has not been published, so I can't present the details of it. But it has informed WHO recommendations for the first all-oral MDR-TB regimen in children, and specifically provided initial dosing in these weight bands under 16 kilo, which I've highlighted here. But it certainly supports additional studies of real-world PK assessment in these younger cohorts. I'll now move on to the nitroimidazole derivatives, drugs including pratomanid and delamanid. Both of these drugs are prodrugs that are activated by nitroreductase enzyme in Mycobacterium tuberculosis, and it is mutations in this enzyme that ultimately result in drug resistance. Primary target of these drugs is cell wall synthesis, and for pratomanid, there's additionally nitric oxide mediated respiratory inhibition, which results in activity against dormant TB as well. As a result, pratomanid is also used for MDR and XDR TB and is, of course, part of the BPAL regimen, whereas delamanid is typically utilized for MDR TB. So I'll start with delamanid. As I mentioned, it's a prodrug. When activated, it inhibits the mycolic acid synthesis, and interestingly, in preclinical studies, delamanid exhibited the lowest MIC amongst approved TB drugs. Unlike pratomanid, delamanid is not active against dormant TB. And again, some features of delamanid I'll go through quickly. Again, it's a highly lipophilic drug with increased absorption with food, which increases the bioavailability 2 to 3-fold. So again, higher gastric pH and slower gastric emptying may reduce dissolution, and delamanid is a weekly basic drug, which may delay absorption. In terms of distribution, it's again highly protein bound with a very, very large volume of distribution. And interesting, delamanid is primarily metabolized by plasma albumin through cleavage of the imidazoxazole moiety, and thus hepatic immaturity has less impact on this. I will mention that pratomanid is primarily metabolized by CYP3A4. And finally, the terminal half-life of delamanid is about 30 to 40 hours, and the time to steady state is about 5 to 6 days. So the primary pediatric trial looking at delamanid in a phase 1-2 PK study of delamanid and the primary metabolite was carried out among children 0 to 17 years of age who were receiving MDR-TB treatment, including an optimized background regimen. Primary exposures were the Cmax and AUC, and these results kind of supported the WHO recommended dosing for children over 6 years of age. As you can see here, children in the oldest age group received an adult dose of 100 milligrams twice daily, and children in the 6 to 11 year kind of weight or age group received half of this dose, 50 milligrams per kilogram, and the Cmax and AUC matched or were above the adult targets. That said, for the youngest group included in this study, they utilized weight-banded dosing as described on the right of the screen. And as you can see here, the AUC and Cmax were below target, and thus this dosing was not advanced forward. Utilizing population PK modeling, they utilized data from this study and incorporated data from all 37 children. And it did provide some additional dosing guidance for this kind of middle age weight band or middle weight band of 20 to 30 kilos, where they found that to match adult exposures, a slightly higher dose of 50 milligrams milligrams in the morning and 25 in the evening, better matched adult exposures compared to just using 25 twice a day, which was what was utilized in the study. Unfortunately, due to the limited number of children under 10 kilos in the study, they could not perform model-based simulations. So the WHO has put out this WHO guidance on delimited dosing, which provides dosing down to the lowest weight bands. And they did this based on extrapolation from older children. They utilized the adult equivalent AUC as the target exposure, and they aim for pediatric doses between 1.5 and 3.8 mg per kg based on earlier PK data sets. They also used both age and weight banded dosing for the band of 5 to less than 10 kilos because of particularly immature metabolism in the children less than 3 months of age and the risk of accumulation. Thus, for children under 3 months of age, they recommend once daily dosing as opposed to twice daily dosing utilized in all the older and adult weight bands. And they also took into account physiologic considerations, including albumin-mediated metabolism, enzyme immaturity, etc. So what do we know about pratominid in children? Obviously, pratominid is a component of the BPALM regimen in adults, and pratominid is not approved for children under 14 years of age. It's the only agent in the BPALM regimen without pediatric dosing guidance. The Impact 2034 study has looked into this in phase 1/2 open label dose finding study that involved a single dose of pratominid in female children with rifampicin resistant tuberculosis. Weight banded dosing is delineated on the right of the slide, and they were able to do this due to the development of 10 and 50 milligram dispersible scored tablets. However, this was not studied in male children due to animal studies that suggested the potential for testicular toxicity, although there's no toxicity has been reported in adult males. So in this cohort of female children, they found that each of the weight bands achieved the adult target exposures for Cmax and AUC utilizing this dosing strategy. However, obviously, the use of this medication is significantly limited until additional safety studies can be performed or additional data can be evaluated for male children. And I'll close this section just with this slide from the working group on new TB drugs, showing all of the many drugs under development for tuberculosis. And this is very exciting. Certainly, drugs in the oxalitinone class, such as linezolid, these newer agents, budesonide and tedizolide, are promising due to potential for lower toxicity, including hematologic and neurologic toxicity. And then other drugs similar to bedaquiline, such as sorfequilin, is an exciting phase 2 development with potential for higher potency and less QTc prolongation. So certainly an exciting time to be in TB pharmacology. So I'll now move quickly on to some gaps in pediatric HIV management, focusing on neonatal ART dosing for dolutegravir, which I mentioned was a large gap, long-acting therapies in children and adolescents, including injectable cabotegravir and rilpivirine, and management of treatment-experienced and drug-resistant HIV, including lenacapavir and fostemsavir. So dolutegravir was evaluated in neonates in the Petite dolutegravir study, which was a phase 1/2 neonatal trial in term neonates exposed to HIV who were dosed within 24 to 78 hours of life. Dolutegravir dosing was as follows. 5 milligrams dolutegravir was given every 48 hours for the first 2 weeks of life, and then 5 milligrams daily up to 28 days of life. The Q48-hour dosing was utilized since dolutegravir is metabolized by the hepatic UGT1A1, and activity is low at birth, resulting in reduced clearance. Additionally, most children are exposed to dolutegravir through transplacental routes from the mother, and so they considered both of these things in developing that dosage guidance. In the study, they saw that the target thresholds were met, and specifically dolutegravir C-min was above the predefined C-trough of 0.67 micrograms per mil. They did utilize 2 different formulations, and the C-max was below the target. It is notable that, of course, all these children were receiving this as part of prophylaxis, and all children were HIV negative at the end of the study. So there really still is no data in children with HIV in this age group, given that most cases are prevented, but it certainly is still an area in need of study. So I'll now move on to long-acting cabotegravir and rilpivirine in children. And this has been evaluated in the Impact 2017 or MOCA trial, which is a phase 1-2 trial including virologically suppressed adolescents between 12 and 17 years of age who are over 35 kilos and received adult dosing. These children were all receiving pre-study ART, either NNRTI or PI-based or integrase inhibitor-based therapy, and depending on what regimen they were on, which they continued, received either cabotegravir or rilpivirine. And in this study, they observed that both median cabotegravir concentrations and rilpivirine were above the minimum week 16 target. So these are the PK findings from the MOCA trial, and again, the primary PK targets are the protein-adjusted IC90 for adults, which are summarized here for cabotegravir and rilpivirine. They also examined the AUC during the oral phase for cabotegravir, and this was above the adult target, and importantly, the C-troughs, the primary outcome, were above the therapeutic targets in adults. So this confirmed that adult dosing is appropriate for adolescents greater than 12 years and greater than 35 kilos. And they continued this trial with many of the children in the first stage or first cohort, plus additional study naive patients. And in this study, patients were switched from the pre-study ART to long-acting cabotegravir rilpivirine Q8 weeks. And they found that, again, trough cabotegravir and rilpivirine exposures were above the IC90 for the drugs, and children exhibited favorable safety, PK, and virologic suppression. So the Impact 2036 study was the first study looking at younger cohorts using non-adult dosing. And in this phase 1-2 trial of long-acting cabotegravir rilpivirine, involved virologically suppressed children 2 to 11 years of age, and they were dosed according to these 5 different weight bands with an oral lead-in followed by the initial IM injection and maintenance IM injections every 4 weeks. And this data was just recently presented at CROI this year, and this showed that the weight-banded dosing of long-acting cabotegravir and rilpivirine after the oral lead-in achieved exposures similar to adults. Additionally, there were no new or unanticipated safety concerns, and grade 1 and 2 injection site pain was the most common adverse event. So now I'll move on to antiretrovirals for heavily treatment-experienced children, starting with lenacapavir on the right side of this image, which is a capsid inhibitor interfering with capsid nuclear transport, capsid disassembly, and capsid assembly. And this medication is given as a subcutaneous injection once every 6 months, which is an exciting development for adults. And we'll review what has been reported for children. And then fostemsavir, I'll talk about, is a GP120 attachment inhibitor. Fostemsavir is a prodrug, and the active temsavir binds GP120 and inhibits CD4 receptor binding. And this medication is given in a twice daily oral therapy. So again, lenacapavir is, given as a subcutaneous injection every 6 months, has a lot of interesting features which make certain pediatric considerations certainly unknown and interesting to think about as additional studies are done. And I will just preempt this by saying there's not a lot of data in children yet, but it's certainly an exciting field and is particularly important as we think about children with advanced HIV and extensive drug resistance. So absorption, obviously in children, the subcutaneous dosing given once every 6 months, there's the potential for more variability in children. The Cmax is about 6 to 10 times the EC95, and there is the potential for higher peaks in small children if weight-based dosing is not considered precise. The primary PK efficacy target is the protein-ingested EC95 of about 15.5 nanogram per milliliter, and again, there's just very limited data in children. And there are other features such as protein binding, heavily protein bound at more than 99%, which may be reduced in certainly neonates, young children, and in settings of malnutrition, and the increase in free drug fraction and its clinical impact are unknown. So what is being done on lenacapavir in children? Well, the PURPOSE 1 and 2 studies were performed as pre-exposure prophylaxis trials, and they did include adolescents over 16 years of age and older. And based on this, lenacapavir lenacapavir has been approved for pre-exposure prophylaxis as well as treatment for adolescents over 35 kilos. And again, this is the twice yearly injection. And currently there is a phase 2 study of long-acting lenacapavir along with optimized background regimen in treatment-experienced adolescents that is enrolling. It includes those who are 35 kilograms and older. And finally, there's a phase 1-2 trial of bictegravir along with lenacapavir in children and adolescents 2 to 18 years of age. There's no data yet from this, and additionally, this is the oral formulation of lenacapavir. So again, there's not much to be done in terms of evaluating long-acting agents like this for adolescent and younger children who may particularly benefit from drugs that reduce the necessity for is close for adherence in the same way that oral daily drugs require. And finally, I'll end with fostemsavir, which is approved for adults with heavily treatment-experienced HIV. The dose is 600 milligrams twice daily. I've summarized the PK parameters there, and currently there is a pediatric study, Impact 2031, that is ongoing that will look at fostemsavir in heavily treatment-experienced children between 6 and 18 years of age using adult dosing in those over 35 kilos and slightly reduced dosing, 400 twice daily, in those between 20 and 35 kilos. So I'll end with just a few points in terms of future research priorities in this area. Certainly, there's ongoing need for further optimizing drug dosing for children, in particular real-world clinical PK, including additional studies on rifampicin, bedaquiline in those younger than 12 years, delamanid in those under 10 kilos, newer ARV medications such as long-acting cabotegravir dolutegravir and rilpivirine, which have really transformed therapy for some adults, and additional data is needed in those under 35 kilos, and certainly long-acting lenacapavir. PK/PD studies for special populations are certainly needed, incorporating variables including severe malnutrition, HIV co-infection, adolescence, as well as difficult to treat infections, including TB meningitis, children with extensive HIV drug resistance. Shortening and simplifying treatment regimens for pediatric patients is certainly still a priority. The BPALM regimen made significant progress in adults. Of course, pretomanid is still not available for those 14 years of age, and some of the newer TB medications in development may make some of these shortened regimens more feasible for children. And of course, safety and toxicity evaluations are needed. Things like pretomanid safety in male children and adolescents, evaluation newer linezolid-like drugs with less hematologic and neurologic toxicity, and those with less QT prolongation. And additional model-informed approaches to bridge pediatric and adult data are needed. So the future outlook for pediatric HIV and TB pharmacology is very exciting. Moving even beyond twice yearly injections is further in the future, but would certainly reduce adherence burdens, particularly important for adolescent populations. Advancing precision dosing through model-informed drug dosing, providing individualized dosing based on patient characteristics. New studies on shorter TB treatment regimens, including more efficacious MDR TB drugs with reduced side effect profile. As always, advocating for earlier inclusion of infants and children in studies, including parallel design, ongoing improvements in pediatric formulations, more integrated TB HIV strategies, and use of biomarker and PK/PD targets to improve identification of exposure targets, safer regimens, and allow shorter trials. And I will end there. Thank you.
Great. Thank you, Dr. Rosenza. Very thorough overview of, I think, where we're at in TB and HIV treatment in pediatrics, but obviously still a lot to do. I think I saw earlier one question in chat, and feel free to add other questions to the chat or to your the Q&A panel here as well. So we have one question that was asked earlier in your talk. Recently, a 4-drug regimen was published for TB. Could you please tell its potential in EP-TB?
Great. I don't know if that refers to the moxifloxacin. That certainly is one of the newer, 4-drug TB regimens for drug-sensitive TB. There is, of course, the BPALM regimen for drug-resistant TB, but I apologize if I don't know specifically the regimen we're discussing, but so these regimens, certainly extrapulmonary TB, the thought is in some cases we may need to treat a little bit longer, and the moxifloxacin regimen was not studied specifically in extrapulmonary TB. It was pulmonary TB, is my understanding, but certainly some of these regimens absolutely, and I do think extrapulmonary TB, including particularly TB meningitis in children, is a priority, given that mortality in these populations is extremely high. We continue to see mortality rates of 30% or higher in children with TB meningitis. So there's a lot of room for ongoing research in that space.
Great. I am not seeing any other comments or questions in the chat, other than thank you for such a thorough overview. And we are right at the top of the hour, so I will thank everyone for attending and my imprint staff for helping facilitate this webinar, and Dr. Louisa for a great talk. So we will see everyone at our next webinar. Thank you.
Thanks so much.